Yeah. No, it's not true. That's not
All right.
Yeah, I was trying to do the other thing. I care.
Let's see. All right, so we're gonna get back to, I know I'm muted. Get away. We're gonna get back to doing the Kahoots probably on Thursday. We're gonna do the Kahoots beforehand. So we're just gonna get through this one, and then I'd still recommend that you guys go. There still are Kahoots for the other chapters, for chapters 11 and 12. So I still recommend doing those. But on Thursday, when we get to chapter 16, we'll do the Kahoot for 15, and then keep on going from there. So we'll have that all sorted out once we fall back into the usual routine of things. But having said that, the lab exam, in case you guys didn't see my announcement, which I'm sure everybody has by now, but everybody, overall, the average was 77, which is really good. This class in particular, 78, just to be clear. So that's way better. And I mean, I am not exaggerating when I had posted, like, I expected 60 as the average. That's not an exaggeration, like guaranteed 100%. Like my first semester when I taught here, everybody was making less than 60 on the first exam. Like that was average anyways, not everybody, but that was a vestige of what I, inherited, I guess you could say, from Dr. Berkala. If you guys know Dr. Berkala, he's the one who developed this course originally, and I've changed quite a lot of it. But yeah, that was something that was hard for me to get away from, even as I was like rewriting the questions and trying to make them clearer and like easier for like as far as the choices and everything like that, but still challenge you guys on the knowledge. I wasn't seeing very much of an improvement in the grades until this semester, whenever we're getting this 77 average amongst all of the sections. And I think it's, obvious. Oh, sorry, did you say something? I heard someone over this. Okay. Anyways, as far as that goes, the only thing that I've changed is that study sheet. That's it. Nobody's ever gotten a study sheet before. You guys are the first ones to get it. And you got a nice, organized, pretty one with everything, the pictures all in one place and all that all in one sheet. And that's the only thing that's changed. I mean, the questions have been the same. I've just mixed them up, or maybe like had them ask them from the inverse side or whatever. Nothing else has changed. So that says to me, and I'm sure probably as we've been going through this, people would agree, the lack isn't in your ability to like necessarily learn or understand or even retain the information, and it's in your ability to take notes and pick out what's important in the information. So if you have all of this information on these slides, and people are just trying to retain everything in all of these slides. Whereas if I give you that study sheet that was nice and pretty and it's actually organized and you can see it and it's not just words, like, a wall of words, then it gives you something to focus on and work on the individual things that might be important. That is the goal with you, what you guys need. That's not me saying, okay, well, now I know what I need to give you guys, because that's a load of shit, right? Like if I just give you the information that you need to know going forward, yeah, you can get an A in this class, but I guarantee you will fail out of nursing school. Yep, you will. Because what I said after that was not a joke. Every semester when my nursing students come back, they come and they say, maybe not to me, but I might overhear them, which is what happened this last time, talking in our little adjunct room area where they were like discussing crap before they're going to go dissect the cadavers and everything, because that's what a lot of them come back to do for work study. Talking about how in their second semester, now they look at the first semester nursing students coming out of their first test crying and being like, yep, we told you. That's not a lie. It happens every semester. I hear that. That's not me threatening you. That happens every semester. That is what is expected in that situation. And I don't care if you're going into nursing school or anywhere else after this. It does not get easier. It gets harder from here. This isn't the hardest class you're going to take. Guaranteed. So you need to be prepared for that. And that's what I want for you guys. If you don't get anything out of microbiology to take past the course, of course you have to do that. But if you don't take anything of this with you from here on out, take good note-taking skills at the very least. Do put in your time, take the effort to, figure out what is important, what you need to be writing down and how to figure that out, because you will need that going forward, wherever you end up going. Because just drowning in the information is not useful to anybody. So don't, let me help you where I can, of course, but there's going to be times where I just can't do it for you. And that's why I'm saying here, like, I will not be giving you another study sheet for the next lab. And typically for the lab final, people do only a little bit better on average on that one, not a lot better. So what I'm telling you is typically people get like 65 average on that one. So y'all will fall to that score if you don't learn how to take your own notes instead of your own notes. Okay, that's the challenge. So I ask you to stand to that. If you can't figure it out, number one, do not wait until the day before the exam to study, or that you dug your grave, y'all. You get to lie in it now. Don't wait like that for any of the exams, especially as things get harder for you into classes past here, you're gonna want to be aware of that. That if you wait until the last day or two before your exams, you're just digging the grave that you're about to fall into. Don't do that. Start preparing beforehand. Because like I said, if you prepare for chapter 11 and chapter 12, the week that we learned those things, at the bare minimum that week, I ask that you do it the same day. I think you will benefit very much more from that. But at the very minimum, the same week that we learn the material, you should have an organized note sheet that makes sense to you from those chapters. If you're going to wait to do each of these right before the exam, you're going to just be in the same place that you were. So don't do that. If you do these ahead of time and have all these chapters, because I would like to point out really quick, when we finish this chapter today, we're halfway through this unit. We only got 3 more lectures, and then you got another exam. So it's not coming slow, it's coming fast. It's going to be here any minute. Yes, you'll have the, that week of the exam and like the presentation day, you have that little bit of buffer, but let's be honest here. Are you really going to be like, okay, now I've got my week of buffer time to really sit down and, do my work here, when you have other classes that are also based on a 4-unit setup that you're probably going to have exams around the exact same time repeatedly for the rest of the semester? It doesn't change. So just get on top of it now, so that whenever you have to study for Unit 3 exam, you have your stuff together. You just need to review it. It shouldn't be learning time then. Learning time is well past once the exam shows up. It's reviewing time. You should have already understood the material and had your notes together. You guys know I'm right about this, but it's just a matter of getting it together, because that stuff, the little handouts that I give you for like the lab exam stuff, that is stuff where we look at the handouts that I give you and you realize this isn't actually that hard. This material is not that hard. It's just, now it's all here and I can see what I need to know. It's not that difficult. This stuff is going to be more difficult. It just is. It's just more content that you have to understand. And you didn't work with it with your hands. So it's not as easy to recall. So you're not going to have a microscope to look in. You're not going to have pictures to look at. It's not going to be like that. So you're going to have to know this material. You know what you're up against, but use the idea of that study sheet from the lab thing, or that first study sheet that I made for chapter 11, use the idea of those to help guide you on your own note-taking process. Please, please, okay? All right, I'm gonna probably plea like this until the freaking end of the semester. Because I know you guys can do this. I know you can, it's just hard, and it's overcoming that hump. Because once you've done it once for yourself, it'll be easy again. Learning to take notes, it takes work at first. Okay, so this chapter, I keep forgetting it's not on this, I'm freaking out. This chapter is going to be talking about the immune system. So chapters 15 and 16, I will definitely be giving the most attention to in this unit, because a lot of 15 and 16 goes into 17. You cannot understand 17 without understanding 15 and 16. It's impossible. So we will probably focus the most in our review. When I do the review this Friday, because I do weekly review, of course, we're going to go over 15 and 16 most missed concepts first. And I had said I was going to go over how I would take my notes on my pre-made notes for Dr. Morford's class, if you guys watched that study video from last weekend. I'm not going to do that. What I'm going to do is start on making a study sheet that encompasses all of 15 and 16, because they work together. Okay, there are innate and acquired immune systems. There's 2 things that work for us when we're fighting a disease. And I'm going to give a little bit of a chart, essentially, of what happens whenever we have an immune response. And I'm going to walk through it on that review. So that'll be after we do the most missed concepts thing. So be prepared for that. It might be more helpful. I had students, the reason I went over my my note-taking skills as far as preparing for a lecture is because I had students who were talking to me about how, I talk fast, and I know I talk fast, and it's a lot of stuff on the slides, and I'll scroll past most of it. If I am scrolling past a slide and not talking about stuff on the slide, that probably means it's probably not important. It's just buffer, or it's explaining the concept, right? Because a lot of these slides have extra information. We're starting to get that a little bit better now, I think, with our note-taking, minds, our note-taking caps on. We can see that some of these slides are just for helping you understand the information. You don't need to be writing down everything on these slides. So if I'm scrolling past it, it's usually extra information. That doesn't mean it's useless. If you have an issue understanding that concept, you can go back to it and look through those slides. It's there for you as well. So be aware of that. But I like to just touch on the main topics and go over those main topics. The extra stuff just helps you understand it. So, but if it's hard for you to keep up with what I'm talking about, I stumble over my words. I know that I do. It's not my fault. It's my brain's fault, I say. And then you just can't keep up with what I'm trying to think. And my mouth can't keep up with all that. So we have, some people that aren't able to keep up with whatever the information might be that I'm talking about versus what's on the slides. And that gets to be a lot. They just shut down. And it's fine, and I understand that. That means, though, that's not necessarily a me problem, because I have to cover the content. That's just it. I don't choose what content goes into this course. There are requirements by the Higher Learning Commission, the HLC, that require that I cover certain things in this course. So I don't get to choose that stuff necessarily. And I have to explain it to you, not just say, know these things, right? That would be a dick move. So I try to fit in what I can, explain what I can. But if you prepare beforehand, if you find that that is overwhelming in class, prepare beforehand. If that just means like looking through the slides, good. But if it means going through and making mini notes like I did whenever I was doing the review last Friday, go through and like say, okay, this is talking about this. And like, okay, I don't really understand. All right, okay, I see this next slide explains it. And then you make down little notes about what you're going to be looking at in the next lecture. It doesn't have to take as much time as I was taking, but it can, however much time you want to take to familiarize yourself with the topic. You have this little bitty like setup of mini notes of what it's going to cover. And then whenever Dr. Morford would be talking in his lecture, then I would be going through and filling out more info so I could understand that material better or see what I missed or what I got wrong and whatever. And it makes more sense to you when you've heard it, quote unquote, when you've read it before. That's the idea. It's like whenever we have our pre-labs for lab, if you guys are actually paying attention to those pre-labs when you're taking them, they should be preparing you for what we're about to get into with the lab, right? You should be looking at it that way and not just randomly answering the questions, which is probably why people aren't getting very good scores on them. So, but do with it as you will. That's the idea. So do that if you need to, if it ends up being a lot. Luckily, I feel like Unit 3 is going to be the end of that kind of stuff, because Unit 4 is going to go over all the diseases. And it's just like me talking about the diseases, maybe immune responses that are special, toxins that they make, whatever makes that disease in those systems. So each chapter is like a body system that is affected by diseases. So you can imagine that in the skin area, we're going to talk about MRSA and like smallpox, that sort of stuff. And then when we get into respiratory, we're going to talk about pneumonia and things like that, or the flu. So we'll talk about what makes those diseases and how our body deals with them, but it's not a lot of new concepts. It's mostly stuff we've already learned that is getting applied now to the diseases. So Unit 3 is kind of that last part of the new understanding new concepts type of video. Unit 4 is a lot of just using that info and applying it to the diseases and memorizing that sort of stuff. So put your back into it, man. Let's do this. If you guys want to, if you find yourself at a point where, usually at this point in the semester, and I don't know how this is going to go now, because you guys put your back into it and you do well on the exams, you could surprise me and actually, keep your grades either going up or, exactly where they are. Because I'm going to be honest with you, when I say that would surprise me if they stayed where they are, oh yeah, that would surprise me. I expect grades to go down the entire semester. Down, not stay the same. Why? Because the exams are worth more than half of your grade, and people usually do shit on them. In case you didn't notice, the exams are worth like 55% of your grade, if not more. It's like really high amount. And people do shit on them. And you're just going to have more. You've got one more Unit 3, which is worth what, like 8% of your grade. We've got one more lab final, that's 11% of your grade. And we've got the final comprehensive, that's 12% of your grade. Y'all, we have quite a lot of your grade left in those exams. It's on you to prepare yourselves well, because I'm not going to hand it to you. You have to show me now that you know how to learn it. Okay. You're going to get all the same resources that everybody else has had, but now you have on your back that tool chest of like learning how to make your notes based on how I've made my notes. You have that they didn't have. So make it work for you. Okay. Okay. Unit 3 is where it's going to really, hinge on. People usually would do better on Unit 3 than they do on Unit 2. So having said that, you guys didn't have these tools for Unit 2, So odds are you'll probably do a little bit better on unit 3 than you did on unit 2, realistically, no matter what. But it's not usually leaps and bounds. Okay. And then usually, yes, people do better on the final than they do on 2 or 3. Okay. but you guys are going to do way better, right? Not just a little better, not just like 70 average. You guys are going to definitely pop it up above that. So I'm sure that you guys are going to do that. So this is getting into the immune system. This chapter is innate immune system versus the acquired immune system. We'll talk about what that means. But this chapter, you can see over here where we have this little, oh, that's a highlighter. Okay, well, whatever. Where we have this little box here, that's innate. It says innate. And then we have the first line of defense and the second line of defense. And it looks like quite a lot of our immune system rests on the innate response. And in a way it does realistically. And we'll talk about how that works and why that works. But it basically is all just because our acquired system takes time to develop. Once it is called in to the fight, it takes a while for it to get everything together. So before we get into that, more bullshit from me. Okay, look, this is my dog Ripley. I talk all the time about meatball and spaghetti, right, guys? And I keep saying, you guys will sometimes be like, you said you had a third dog. Like, where's this other dog? This is Ripley, okay? And she's cute and she's old. And she's like 12 years old. And so she is now anyways, but she still plays with the boys really well, runs around, jumps. You would never know other than her little like white little graying muzzle that she's getting older, but she's doing pretty good. And this is the motorcycle that I bought. As I had mentioned, I think I've mentioned to you guys about it before. I said to my husband, oh, you want a motorcycle? Isn't that cute? Here, you need to get the motorcycle rider's course. And I sent him a little text about that. And then he came home to like this little letterboard thing that said, I couldn't fit anniversary, so it just says verse, but happy anniversary, you're gonna need those lessons. And then I bought him this motorcycle and he continued to fall off of it like 5 times, you guys. And it would just be like on the ground. And I'd just be like, I just financed this. And I was like, look at that, like on the ground, like on the concrete. And I'm like, yeah, you fall sometimes when you first start riding. And yeah, so he was just really stubborn. And I was trying to tell him, like, just why aren't you holding the clutch? Like, why can't you just hold on to the clutch? Because he kept pulling on the brake when he would freak out, but without grabbing the clutch. And I don't know if you guys know anything about a standard, like if you drive like a manual transmission, if you do that, it kills the engine every time. And so when you kill an engine on a motorcycle, it kicks and the whole thing would like kick forward. And when he would do that, he would just like abandon and like let the motorcycle just fall like you would with a bicycle or something if you freaked out on a bicycle, except that it's way more expensive than a bicycle. So I was like, oh, what did I do? But it got to the point where I was just trying to be really supportive and try to remind him about the clutch and shifting and everything like this. But he was like, I'm gonna pull it into the driveway. And I was like, how about you get off the motorcycle and let me pull it in the driveway? Like, I should get off of that now. Anyway, so it's going to be fun, I'm sure, right? It's not going to be totally me just freaking out the whole time. Anyway, so immunology is basically our body's ability to like undergo surveillance for foreign things. Look out for these bad guys that don't belong there, recognize them as bad, and then eliminate them. So this is a lot more going on here than what it sounds like. It's not as simple as just shining a flashlight out and trying to see if there's bad guys there. First of all, we have to recognize a bad guy as bad versus self. And your cells, like your immune cells, have to be able to tell the difference, especially if they're going to go out and creating all these toxic chemicals that break down things and kill things. You want to be sure that you can recognize self from non-self so that you're not attacking the wrong thing. So this is going to base on, generally speaking, on antigens. We've learned about this as anything that your immune system can react to as foreign. So markers that we can see as non-self, and it has to be identified by the immune response. And so that is a part of the component. Just because it's non-self doesn't mean that the immune system can see it as foreign. So for example, water is non-self. We wouldn't want to react to that though, right? So that needs to be something that we could eliminate from concern. So we have to be sure that we're being safe to our actual own cells and any other components that might be important for our survival as well. So it gets tricky being able to tell the difference. If you don't take care of that self versus non-self thing, then you can have development of autoimmune disorders. And we're going to talk about this in a little more detail in chapter 17. we have to get into more about how antibodies are made and immune function of antibodies in our cells that help attack all of, infected cells and everything, our T cells and all that. So we want to be sure that our body's seeing self as self and non-self as non-self, but sometimes the wires get crossed. Sometimes, let's say during you're sick with something and your body's responding to that virus or that bacteria. And what will happen is in the meantime of, sending all these signals to attack and doing all this killing and everything, you start overreacting to self molecules that didn't get properly regulated earlier on. And then you can develop autoimmune disorders. And that's kind of what we'll see happening. There's other things that can go wrong as well. Type 1 diabetes, yes. So I would probably the most, I don't know, like the incidence of what the other ones are, but it's very common. Yeah, you're absolutely right about that. But it is an autoimmune disease. And if you guys did not know that, for those of you who might not have known that, yes, type 1 diabetes is absolutely an autoimmune disease. It's the body attacking its own cells.
It just seems like it's so prevalent.
Yeah, it is pretty common. Type 1 is pretty common. I mean, type 2 is way more common, unfortunately. I mean, that's America though, right? So that's just the facts. But yeah, it is pretty common. And they think that a lot of these things have to do with other infections that you have either had in the past, or that maybe how the body responds to those infections in general is now being misdirected to these areas. And it's hard to prove that stuff, but that's what they're thinking, that it has something to do with like measles. And so it could potentially either have to do with having the measles or having been exposed to like the measles vaccine. Just the reaction to measles in general can trigger, they think, certain autoimmune diseases like type 1 diabetes, which I think that's what they're linking it to right now, but I'm not 100% certain on that. And anyways, on the innate immune system side, we talk about antigens, but antigens tend to be something very specific that we have a very specific response to that antigen. So with the innate side of things, their equivalent are PAMPs. And PAMPs, it stands for pathogen-associated molecular patterns. Okay, and you do have to know that one, that acronym. This is essentially things that you can associate with bad guy. Easy concept here, okay? Peptidoglycan. Is that part of your cells? No. Your body can see any presence of peptidoglycan and say bad guy. And it should. That's a good marker, right? That's a way to identify. But does that, if you recognize peptidoglycan, is that specific to any specific kind of infectious, bacteria? No, right? It's going to be like any bacteria pretty much. So these guys are going to be generalized response. So they'll see peptidoglycan, that's a bad guy. They'll see LPS or endotoxin, that's on gram negatives, right? They'll see that, bad guy. And another one that's common is going to be double-stranded RNA. Our RNA is all single-stranded. It might have a couple of little nice bends and squiggles or whatever, but viruses can have actual double-stranded RNA genomes, and we don't. And so when we see double-stranded RNA, that's another sign of this is a bad guy automatically, but it doesn't pinpoint a specific virus. It's not like we're attacking flu, let's say. So anything. So these are generalized markers that help our immune cells say, this is a bad guy, and this is not self, right? So those are PAMPs. Yes, they recognize it with these things called pattern recognition receptors that I'm never going to test you over, but definitely know PAMPs, okay? And the concepts of them. So we're going to use that concept of these foreign molecules and the fact that we always have our self molecules around to train our immune system while it's developing early on, the difference between self and non-self. So this is where we're going to kind of start at with our innate immune system. So they're going to know our PAMPs. Next, we have the mononuclear phagocyte system. These are just all of the tissues that are part of the immune system. And this top one, the mononuclear phagocyte system, is going to be a newer concept. We're going to talk about it more in a minute, but really it's not going to be any different than what I'm about to say, which is just that it's like our system that allows us to go between tissues and areas in tissues. So it's our transport pathway. It's going to be the collagen fibers. It's going to be other fibers that are involved in the extracellular matrix that allow our cells to go between tissues. That's all it is. We have things like our extracellular fluid, our bloodstream, and our lymph that also allow for things to move around within our body so we can transport cells where they need to go in response to things, to the bad guys. All right. For the lymphatic system, it's more, you can think of it as our return system of that extracellular fluid back into the circulatory system. So all of that fluid, we're going to talk about the inflammatory response in a minute, but you go stub your toe on your coffee table and, it'll get like all red and swollen and all this in your inflammatory response. And that's not just something that just happens because, oh, you hit your toe in pain and then it gets swollen. Literally what's happening in the background is our inflammatory response that's causing all of that to happen. And so the things that mediate this will be signals sent by cells in that area where the injury was. So if you stub your toe or if you step on a nail, right? That's an easier one because we can actually introduce bacteria into this and we'll get to that point. But you step on a nail, you step on a tack. Your kids were playing with something, I don't know, and you step on a tack in your living room and now your skin has been punctured and bacteria could get in. So the cells in that area send out chemical signals because they've been damaged. And there are other cells nearby that are related to the immune cells that they themselves aren't going to be doing any attacking or killing of bad guys, but they know that there's injury because of the cells nearby sending signals, and maybe because they recognize that there's bacteria in the area. But they'll send signals out. Again, these are just chemicals the cells are making that get leaked into the bloodstream and call other cells in, right? When those other cells come in to help defend, that can actually eat up and destroy the bad guys, when those guys get called in, they're coming from the bloodstream. And the way they're going to be able to move out of the bloodstream and into that tissue where you stepped on your nail or tack or whatever it is, they have to come with fluid. And so that extracellular fluid, the fluid that they're coming in with, which has like their nutrients and their, again, chemical signals that we're calling them there, everything like that, they come in with that fluid into that area. And guess what? That's what causes the swelling in an area. So whenever you have buildup of that swelling in that area, and it's outside of the tissues and it's building up there, we call that exudate, and that builds up to form edema, which we will talk about this in a minute, but this is the general concept of what's going to be happening there. But you have to get the fluid there to get the cells there, and you need the cells there to fight the good fight, right? So if you're bringing those guys there, when it's done, when you're done fighting the good fight, you've pulled the tack out, you're probably not going to get an infection thanks to your immune system, probably your innate immune system. You pull that tack on, you're going to be fine. But when that's all done, that fluid doesn't just stay there, does it? That eventually your swelling is going to go down in your, foot or whatever it was. That's because that fluid is getting reabsorbed back into the body. But it's not as simple as it just, dissipates into the ether or something. That fluid has to get back into the circulatory system. But first, because our body isn't stupid and it knows better, first, that fluid that comes back out of that injured area goes into the lymphatic system. It does not go right back into the circulatory system. It drains into the lymphatic system. And this way, you can go through lymph nodes and other lymph tissues that are going to filter out and examine that fluid. And we should, because you just introduced bacteria. And we don't want any puncture wound introducing bacteria, allowing the fluid to come back into the lymph system and rejoin the circulatory system without being checked first. So that's what the lymph is there for. It's separate because we want to screen it before we rejoin it back with our circulatory system. Make sense? So that's what we're going to go there for. It's our drain off system. Yes, it's how we're going to get the fluid back into the circulatory system, but we're also going to be checking it. We're going to go through surveillance too. It's like
Like TSA.
That's exactly what I was going to say. So maybe, yeah, sort of like TSA, but I was going to say when you go traveling, like if you were going to Europe, you can just drive from country to country and you might have checkpoints where you have to show your passport and get it stamped or whatever, and everything's okay. It's not like, traveling back into America from Mexico. It's way easier. Maybe more like traveling back into America from Canada. Okay. So you can get your passport checked or swipe your passport card or whatever it is. And that's all that this is going to be, is going through the lymph nodes and everything, checking and making sure everybody is supposed to be there like they're meant to be. Or if you're a bad guy, getting rid of you somehow or triggering a better immune response. So we know this lymph is just that fluid that is traveling from the extremities back into the circulatory system, but being, essentially processed first. So that's all that it is. It's all the fluids from your extremities getting processed back into the body. So there's a problem with the lymph. So we have our lymphatic vessels and they're all over the place. I don't know how much you guys, I haven't taken anatomy in case you guys weren't paying attention in that little review video, but I haven't taken anatomy, so I don't really know much about what it looks like in real life. But I'm imagining that it's hard to find lymphatic vessels in the body, specifically because they're not as, strong as the blood vessels and the arteries and the veins. But because there's so many of them and they're just so fine, there's more of them actually, because they're growing way more, dealing with more of the tissues and bringing back all those fluids that were in those extremities, because they need to be sure that it gets filtered and dealt with properly. So it's really always there and it's always acting as a surveillance system. It's just we don't think about it a whole lot. You bump your elbow on something, you hit your elbow really hard on the edge of this thing and it hurts really bad. You'll have some swelling and bruising and things like that. Your inflammatory response is acting just the same way. It's just there's not an open wound. So it's still dealing with the injury that's there. Okay, so you've got your lymph that's in your swollen elbow, that's in your foot that you step on the tack, and it needs to go back into the circulatory system. We're going to get it there, but we're going to filter it on its way, and it can only move from extremities back to the heart. Because remember, the fluid that got there in the first place, it came from the bloodstream. It didn't need to be separate on the way out. So it just moved out of the bloodstream. And now on its way back, it has to go through the filtering process before it can rejoin. So lymph only moves in one direction, and that is from the extremities back to the heart. And it's only transported through the contraction of skeletal muscles. This is why if you have surgery or have ever known anybody who has had surgery, they want you to get up and ambulate, walk around as soon as possible, because it helps your lymph start circulating and start getting your immune system, mobilized so that we can actually treat whatever the infection might be via our immune system. So that's the idea of that. And if you can't move, they'll often put like this little squeezy things on your legs. When I had my tonsils out, I had my tonsils removed as an adult. And I wake up and they had these little squeezy things on my legs. And it's just like they alternate. And like that's specifically to keep that lymph moving to help you heal from whatever your procedure is. So it can be pretty devastating if you are not moving around. And I'm sure if you guys are going to nursing and if you guys worked in any healthcare whatsoever, you will notice that if somebody is unable to ambulate, if they can't move around and get that lymph moving, you will see edema in their limbs, and they'll swell up. You'll even see swelling feet and stuff, even though they're not on their feet using them, because it'll just drain to these areas and just sit there and not be able to come back.
The machine that we use is called SCDs, and it's a requirement for all patients who cannot get up and manipulate.
I mean, that makes sense. It should be, yeah. So this is my terrible drawing of how this is working. We have our lymphatic system. That's our heart that I drew the purple just to show you that's what I meant by this area. Okay. And you have your blood coming out and your fluid here carrying the cells. That's what those little circles are. The cells in the little fluid going into your foot or whatever it is, right? Came out of the actual blood itself. And it's just showing our circulatory system. And then the next part over at the right, we have the cells and the fluid from that area come in via the lymphatic system to rejoin the circulatory system to go back towards the heart. So they come back, that part down here, this is like a lymphatic vessel. Okay, and that's going to be driven by muscle. And this is an example of what the circulatory system versus the lymphatic system, and then how they kind of connect to one another from like an extremity. It's a better picture than what I was drawing with the ugly heart. All right, lymphoid organs that are involved in the functions of the lymphatic system. The primary organs, which might not be what you think it would be, the red bone marrow and the thymus. The red bone marrow is where all blood cells come from, white or red. Okay, they come from the bone marrow. And then the thymus is the organ where your T cells are going to be maturing. And it's in your chest, and it shrinks as you go through adulthood, sometimes to almost non-existent levels. But in your younger years, they'll be nice and healthy, because that's where we're training basically our T cells up to be, working properly, what they're supposed to do. Then our secondary lymphatic organs are going to be your lymph nodes, spleen, and your associated lymphoid tissues. That's what the ALT is. And we'll talk about which one of these, what they are in a minute. But it's just essentially, like it says, tissue framework that has lymphocytes. It's like a spread out tissue area of, like if you spread out a lymph node. It's same function, but it's kind of spread out. All right, so the bone marrow, all cells, all blood cells of all kind, red or white, are going to come from the bone marrow. B lymphocytes, when we get into our lymphocyte talk and the acquired immunity, B and T lymphocytes are acquired immunity. And so the B lymphocytes, they go through their entire maturation process in the bone marrow, whereas the T lymphocytes will get made in the bone marrow and then go and mature in the thymus. So there's a difference there. So cool. So this is our little organ where the T lymphocytes are going to finish their development and everything. The lymph nodes themselves are essentially going to act as our filters. So all of that fluid coming back to the circulatory system, going to go through lymph nodes or similar tissue like the ALTs. And they're going to get filtered so we can find any bad guys that are going through there or any debris or something like that, so it can be removed before it rejoins the circulatory system. And there's also cells there. Obviously, there's cells there that are going to be part of the immune system that can deal with that. So there's not just the checkpoint, right? There's also guys with rifles standing in the background. All right, so it's lymph nodes, whatever. Lymph nodes are about the size of not even like a pea. They're about the size of a pea naturally, if you're healthy, if you're not having an infection, which should really put it into perspective whenever you feel like those swollen lymph nodes in your neck and they're like big, because they are normally pea size. And I can attest to this because when I worked in the transplant lab, we would get lymph nodes in from the donors, the deceased donors, brain dead donors that would donate whatever organs, and we get lymph nodes from them, and they were little tiny things that we would have to like get the cells out of in order to do the testing with it. And they're super tiny. They're not big like how you normally feel. But if they're big, that usually is going to mean that, of course, the cells there are multiplying and getting ready to react to or are reacting to an infection. So that is what's going to be causing that swelling. You can have them generalized all over your body, kind of swollen, or you can have them localized, which we usually see if you have like a cold or something, kind of in the neck and throat and ear area. Yes, yeah, it does. Yeah, they don't like, I guess, like whenever they're multiplying like that, it's just too painful. But that does really put it into perspective, though. You think of how tiny cells are, and you don't see cells individually, right? Especially white blood cells. Like you take someone's blood, you don't even see the individual red blood cells, which are tinier, just to be clear. But still, you don't see them. So all of them are multiplying that much to cause your freaking lymph node to swell that much. That's very impressive. That's how many of those cells are going to grow up and respond and create like an immune response against pretty much any time that you have, an invader like that, where they're called to action. So the spleen is a lymphoid organ as well. It filters, we know it filters out red blood cells, right? That's what it does. It filters the blood itself. It is not filtering lymph. It is filtering blood. But while it's filtering blood, it also has other cells like macrophages, other phagocytes that can deal with anything that it finds in the blood while it's filtering. Because we might as well, if we're filtering out, red cells, might as well check for bad guys too. So they have the macrophages on site in order to deal with that. Don't worry, you're going to learn what a macrophage is. So these are our associated lymphoid tissues: skin, mucosa, and gut. And we also see like tonsils aren't lymph nodes. They're just an associated lymphoid tissue, similar function though. And then breasts of pregnant and lactating women can have similar tissue that's in the area that will have similar functions too. All right. Associated lymphoid tissue. They work like the lymph nodes, but they're just diffuse, like kind of spread out. All right. Whole blood. If you guys are going into nursing and you're going to be drawing blood and going into the phlebotomy aspect of all this, if you're a good nurse, you will be a good stick, hopefully. I'm looking at all y'all. Okay. I was talking to my husband about this and I was like, yeah, because he was like complaining because he works for OBI. And he's like, yeah, we have these big old needles. I don't understand how people can't stick people with the little needles. I said, honey, the people that come to you are healthy and are volunteering to be stuck with a needle. When you draw blood from somebody in a hospital, they are not healthy and they don't want you anywhere near them. So good luck with that. So yeah, I mean, his needles that they use in the blood draw for OBI, they're like 14 gauge needles. They're huge. So it's put it into perspective, my nose ring is 16. And so it's bigger than that. And to me, it looks a lot bigger than that when I see it. But they call it 16, but that's the bore that's inside. The bore actual hole inside is 16. And then altogether it's 14. Easy. It's huge. And so he's like, yeah, if I could stick with that. And I was like, yeah, okay, whatever. Yes, when you use vacutainers, just to be clear, those are 20 gauge needles. They're much smaller. And yeah, when you use a butterfly, it's 22 gauge. So yeah, even smaller than that.
Or like every time, like if my doctor puts in an order for me to get one, I tell him use butterfly.
It's easier to stick with for sure, but you risk hemolysis. So because it's a smaller needle, you're more likely to have damaging of the red blood cells if you have this issue. So better to risk if you're starting, you know, you want multiple tubes, like a lot of tubes, the butterfly is better because it's not moving around as much. With the vacutainer, it's just going to give you better quality sample if you can get it. Anyways, I only say this because I work for DLO, and I worked at DLO in Southwest. And I worked in the lab, yes, but their lab people are also phlebotomists, and they're dealing with phlebotomy of people who can ambulate at the hospital that need to get blood draws. So they are sick people, but phlebotomists, it's just a fact, and I'm not trying to say this, but their focus is on like drawing blood and doing that, you know, in and out, and that's what they do. Nurses, that's not their focus. So nurses tend not to be, I'm not trying to say anything about it, tend not to be as good a stick as phlebotomists, because phlebotomists just, that's what they do. They don't do any other thing. So the nursings do all of it, and the nurses do all of it. And so yeah, it's fine. It's not their focus. It's whatever. And some places like Mercy, they have floor phlebotomists that they can call up to patients and things like that. But Integris doesn't work that way. Yeah, so you have to just anchor them. Yeah. But anyways, so the tubes is what I'm trying to get at. Okay. You have like the red top or the tiger top tubes. Those guys don't have any additives in there. You might see like it has that stuff at the bottom though, that's stuck down the bottom in the tiger top tubes. That's just wax to help separate. Okay. That will happen in the centrifuge. But green top tubes, the blue top tubes, the pink top tubes, all of those guys have something in them to keep from clotting. So that anytime that you have something in there to keep the clot from happening, they're going to get plasma from that, not serum. Serum comes from the clotted. So you let the blood clot and then you spin it down, and then the liquid on top is going to be the serum. You use that for immunology studies because that's where all of your antibodies and stuff will be. You needed to separate out those blood cells and do that. Otherwise, it can interfere with the plasma. The stuff that's in those tubes can interfere with the collection of those antibodies. Anyway, so there's a difference, is what I'm trying to say. Plasma, no clotting. Serum, clotting. If you ever heard of serology, serological testing is immunological testing. It's the same. So serology, serum, in case you can't tell, that's where that's coming from. Okay, survey of blood cells. We know that if you're getting a blood cell, white, red, whatever, you have to go through hematopoiesis. This is development of our red and white blood cells from our stem cell precursors in the bone marrow. Stem cells could potentially become any of the blood cells. So the stem cells in your bone marrow could potentially develop into any of the blood cells at, you know, if you go back far enough on their maturation process. So I'm not going to go over it any more than that, really. You can learn that in physiology. The white blood cells are the ones that we're going to be most interested in for immunology. This is going to be also known as the leukocytes. We have lymphocytes and we have leukocytes. Leukocytes, all of the white blood cells. Lymphocytes, the B and T cells. Okay. So you can split up your leukocytes into two categories, basically based on how they stain, if you're looking at them in a stain under the microscope in like a hematology lab. Okay. And these are the granulocytes and the agranulocytes. And that's it. So the granulocytes, and again, cytes, you guys know that that's cells. Granulo, they have granules. All that means is you see little dots all in there. Looks like granules. Then the agranulocytes don't have that. And they also have a larger nucleus, typically. That's the differences. Granules are not. That's all. Okay. So now that we've established that, let's look at our agranulocytes and our granulocytes. Let's start with the granulocytes on the right. Generally speaking, your granulocytes are going to be your fills and your mast cells. On the exams, whenever I'm talking about granulocytes, I'm almost always just going to talk about the fills. I'm not going to give you like fills versus mast cells or something like that. The mast cells fall into here. We're really not going to talk about them very much, except in chapter 17, we'll talk about them briefly. But the fills, y'all, neutrophils, eosinophils, and basophils. Those are the fills, okay? They all are granulocytes. The agranulocytes are going to be our lymphocytes and our monocytes. I say that there's two categories. You see all this whole list over here on the left, but the lymphocytes encompasses our B and our T cells. We already said that. And our monocytes, it's like a parent or a precursor cell. Once that cell moves out of the bloodstream and into a tissue, it differentiates into a macrophage or a dendritic cell. So it's the same thing. It's just in a tissue. All right. So that's why I say lymphocytes and monocytes. Lymphocytes and monocytes and its derivatives. So that's it. That's the agranulocytes and the granulocytes. And these are all of the cells that you are going to need to know about for the entire immune function. Pretty interesting. All right, let's back to the mononuclear phago, whatever, MPS. I always just call it MPS. Let's just stick with that. Yeah. Mononuclear phagocyte system. Again, support network that allows tissues, movement between tissues and between cells by our white blood cells. That's all that is. All right, our monocytes are agranulocytes. This is one of our agranulocyte categories. They give rise to the macrophages and the dendritic cells, like I was saying. And once they get into certain tissues, they can specialize in those tissues. So the ones that hang out in your lungs, for example, where I have the star, that's the alveolar macrophages. So they've moved into the alveoli where you have the gas exchange in your lungs. And they just hang out there and wait for it because you breathe stuff in all the time. They wait for that. Cytokines. This is a good thing to be aware of. Term, that's what I'm trying to say. Cytokines are chemical signals sent by cells. And there's all sorts of different chemical signals that they can send. You may have heard of some of them, whether it be interleukins or tumor necrosis factor, TNF, interferon. We can talk about that one as well. But all of these guys are cytokines. Any chemical signal that's going to aid in our other cells coming in and doing certain things. So they can help with inflammation. They can decrease inflammation. They can increase or decrease blood flow to the area, and they can act as growth factors to trigger our lymphocytes to start, multiplying and activating. Don't really need to go, huh? Yeah. So they're just chemicals that the cells make. And here are some examples of these cytokines. So if you ever heard of cytokine storm, people say like you could have cytokine storm with COVID, or you can have cytokine storm when you have certain autoinflammatory diseases or whatever. This is your body making too many of these signals all at once, like an inappropriate amount of these, causing the rest of the downstream stuff to then get activated and start fighting whenever it doesn't need to be doing that much. So it's a cytokine storm. So some examples, look at that. We have one up here that you guys definitely recognize, and that's histamine. Histamine is made by our mast cells and our basophils, and it's going to target our blood vessels, our sensory nerves, and our neutrophils to start calling them into action. So these are just examples of stuff. I'm not going to test you over our individual ones. All right, let's go over our physical and chemical barriers. These should be obvious, okay? This is not trickery, I promise. The skin. If I literally deglove your hand, okay? We take the skin off of your hand. It's gross, and also you're going to be more susceptible to infection. So the skin is actually protecting you from that. And it's the junctions in between the skin cells, the thickness of the skin, and this protein, keratin. Yes, it's in your hair as well. And it's a waterproofing protein, and it is helping protect your tissues underneath. We also have hairs and skin glands. Your hair will trap things, and your actual skin glands flushing out with sweat and oils and things like that, keeping microbes from sticking. Some of this stuff is obvious as far as like, oh, I could see how that could protect. But then at the same time, you're probably also thinking that's not its main function, though. Correct. But it still has this function for us, right? Mucous membranes, they're moist and permeable, which can be a bad thing, but it's also a good thing because we have this fluid, turnover that can get rid of these microbes. Harder for them to stick onto surfaces. We don't have the keratin to protect us, so we have to have that fluid essentially helping out. So we have blinking and tear production in eyes, saliva in the mouth to get rid of microbes, to help you swallow or spit and things like that. Even swallowing is part of our defense. Okay, come on, dude. The respiratory tract, we have nasal hairs, obviously, in your nose to help catch things and prevent them from getting deeper into your respiratory cavities. And we also have the ciliated epithelium, which is all of the little tiny hairs, the cilia on the cells in your lungs and lung passages that are constantly moving mucus up out of your lungs. That's what, like if you're getting sick and you have a lot of mucus production, they'll move that up and then you'll cough it out and that sort of stuff. So it gets it out of your lungs. Okay, the genitourinary tract, urination and vaginal secretions to help flush out and remove microbes, as well as the pH of the vagina as well, which I think they're considering as a chemical. But our microbes in our normal microbiota provide microbial antagonism. They take up the stadium seats. They use up the nutrients. They might change the pH so that the other things that are nearby don't want to associate with it. They do all of this stuff for us to keep us safe. And then some of the chemical defenses might include lysozyme. This is in tears and saliva, and it hydrolyzes peptidoglycan. Remember when we learned about the different kinds of enzymes and we learned about hydrolases versus ligases? They were like the opposites of one another. And we know DNA ligase helps join things together. So now we know that hydrolases, when you're hydrolyzing something, are ripping things apart. So we're ripping apart peptidoglycan. That's a neat trick, yeah? So that's a lot of bacteria that we can defend against just with that in your spit and in your tears. Stomach, yeah, right. And so then what are we talking about? Osmotic pressure? Yeah, okay. So stomach, hydrochloric acid, we know this. Bile is a little bit basic, but it's the digestive effects of it that have the negative effects on our microbes. Semen has antimicrobial chemicals, and obviously we said before, the acidic pH of the vagina that's maintained by the normal biota. So I made a little summary chart of all of those so we could see all of our first line defenses together, and maybe some terms that we might want to be aware of. Most of the stuff we're aware of, they exist, and so it's not anything special. All right, let's move on to phagocytosis. We talk about it all the time, and we are finally there, you guys. We're finally at the part where it's like doing a thing. So phagocytosis, we're eating up bad guys, whole bad guys, right? And our main phagocytes are going to be our neutrophils, our monocytes, and our macrophages. Remember, macrophages are just differentiated monocytes anyways. So, but you will find out probably pretty quickly that our first presenters at a site of an infection are going to be our neutrophils, sure, but the ones that are really driving the overall immune response and maintaining all of it and acting on both sides of the spectrum, the innate as well as the acquired, is going to be the macrophages. So the macrophages are like the big daddies of all these responses. So So neutrophils are reacting early on in the inflammatory response. So you get stepped on that tack, there might be things like mast cells that are already in those areas. They are not phagocytes though, right? They weren't on our list of phagocytes. So mast cells, they are granulocytes. They see bad guy coming in with your tack. So they start releasing the granules. The granules are just the cytokines and the signals to call in neutrophils. So the neutrophils come in from the bloodstream. They squeeze through the walls of the blood vessels. Literally, that's how they get into the tissues. It's crazy to think about, but between the actual cells of the blood vessels, they'll squeeze in and then start fighting the good fight. Neutrophils make up a majority of your white blood cells in your bloodstream, 55%, easy, 55 to 65% in a healthy person. You're going to have even more whenever you are having an infection. We also have these other phils. This is eosinophils. They can be involved doing similar function, but it's usually associated with parasitic infection, but you also see them elevated with allergies. My eosinophil counts are always high because I have allergies. All right, our monocytes and macrophages, they're basically going to go around eating things up as well. So we have our neutrophils, phagocytes, our monocytes, and our macrophages, also phagocytes, going around and eating up. A lot of times too, like the neutrophils get there first. They'll eat things up and just like crap out all the waste. So they're like, eat it up, dissolve it down and poop it out and then keep doing it out like that. The stuff that they're pooping out can't just stay there, right? It has to get gotten rid of properly. So the macrophages will come and clean that up, but that's really important too. We'll come to why in a minute. So first, here's the phases of phagocytosis. Chemotaxis, we learned about this with bacteria, yeah? How they can move in response to chemicals in the area, the smells of the cookies, right? So our guys are moving via chemotaxis. It's usually the cytokines that they're smelling, quote unquote, okay? Then they'll ingest it. They'll form a phagolysosome. We'll talk about what it is, don't worry. And then they'll destroy the thing and excrete it. So here's how it goes. Chemotaxis and ingestion. They're going to get called to the area by the cytokines. Easy enough, right? They got called there. That's their chemotaxis. Now they see, okay, now I'm here. What do you want me to do? The cells aren't going to tell them, hey, this guy over here. That's not what they're doing. Not yet, anyways. What they're doing is everybody there is freaking out. The neutrophil comes in and it just starts eating up crap that's around. And it realizes that whenever it goes to grab onto it, if it sees a PAMP, okay, we're eating it and digesting it. If it sees a PAMP, eat it and digest it. It sees a PAMP, and that's all it's looking for is these PAMPs. It's not looking for anything else, okay? Cellular debris, it will eat that up as well. If we had dead cells, like you step on a tack, you probably have some damaged cells. It'll eat that up and digest it too. But it knows for sure that if I see a PAMP, I'm going to eat you up and digest you. And that's really what these phagocytes are going to be doing up front. And we already talked about peptidoglycan, LPS, which is endotoxin, and then we have double-stranded RNA. All right, so you eat up this bad guy. You say, oh, what even is this? I was going to use this as an example, but no. Controller, okay? You saw the controller PAMP, and you eat it up, and you got it in this little vesicle in your body. Well, in your cell body, right? Your cell. And we call that a phagosome. Zome is just a vesicle. So we've got it in the phagosome because we phagocytosed it and made a vesicle around it. Now we're going to take a lysosome, which is another vesicle that contains dangerous chemicals to digest, to kill. It has some of our reactive oxygen species, like free radicals, like the ones we talked about with the hydrogen peroxide. That stuff's all packed in there. And we have actual lysozyme as well, all sorts of stuff. We're just going to merge that phagosome with our lysosome toxin vesicle, put them together, and it kills them. Within 30 minutes, the bacteria will be dead. It's pretty effective. That thing, when it's combined, is called the phagolysosome. That's all that is. All right, moving on to signs of inflammation. These are Latin words, and I don't know my Latin very well, and I don't speak Spanish either, both of which would be helpful if I was learning these. But rubor, calor, tumor, and dolor. Rubor is the redness. Let's think of like ruby if you don't know, Latin or Spanish. Rubor is redness. Calor is warmth. Remember, like if you think about calories and you're burning calories, well, that's not a joke. A calorie is literally a measure of heat that is coming off of burning something. So the energy that comes out of burning a carbohydrate, that heat energy that comes off is literally a calorie. So calor, warmth. Tumor, swelling, that's from the fluid coming into the area. And then dolor is the pain that we see from stimulating the nerve endings, usually from the swelling or the actual injury itself. You want the pain just because that way it lets you know that you have an injury. Not always helpful, but it does have a thing, does something. And we also might have loss of function in that area as a result of all of this going on too. And then chronic inflammation, obviously this makes sense, but can lead to development of other disease presentation. If you're constantly having inflammation in an area where we're triggering this fluid, we're triggering the redness, we're triggering the warmth and all this, it can cause damage in those tissues long-term and present as a different kind of disease that might not seem related. All right, what does inflammation do for us? It attracts our immune components. So part of the whole reason that fluid is even getting into that area to cause that swelling, that tumor aspect, is because we have to bring the immune cells there to start fighting. We set in motions the repair mechanisms, which we don't really talk about that much in this class, but and then also clearing away any harmful substances. And then we're going to destroy microbes and block their invasion, which is kind of the big deal of all of this. So this is just walking us through kind of what would happen if you did step on a nail. First, you've got your injury, introducing bacteria. The cells that are in that tissue area are going to release signals saying, uh-oh, this is bad. Then our neutrophils are going to come in. It's the one below. We're going on 1, 2, then 3, 4. So in below, we have our neutrophils coming in with the fluid that they're always going to be coming with, and they're going to come start eating up and attacking these bacteria that are in the area. And again, more signals for the response of the inflammation. As the fluid builds up and the neutrophils build up and there's bacteria in the area, and we've got this whole big old fight and all the waste from breaking down these guys, that's pus. So pus is mostly neutrophils, actually. And then once we start eating up that guy, finally, we get our macrophages in here and our lymphocytes. The macrophages are going to come and clean up, quote unquote. And when they clean up, they're going to help recognize some of these more specific bad molecules that it can present to the lymphocytes and help activate them. Because remember, lymphocytes, B and T cells, they are only activated by very specific antigens. They don't react to PAMPs, only very specific antigens. How do they see those specific antigens? The macrophages show it to them. That's the next chapter though, so don't worry about it right now. Cool, yeah. I didn't highlight on any of this, which kind of says what I feel about it. You'll have changes in your vasculature. Your blood vessels are gonna, get bigger. Sometimes they will constrict to help contain an infection. It just depends on what signals they're getting from the cell too. But most of the time you'll see like vasodilation to bring blood and the cells that are in it to an area. Exudate, like I said, this is our bloodborne components into the extracellular space. This is what's causing your tumor, that fluid that's getting into that area with the cells. And then the firmness that we feel and the swelling that we actually see as a result of that exudate is called edema. How do those cells, we saw a little picture of them kind of squeezing in between the blood vessels, and I even said they were squeezing between the cells of the blood vessels. So when we get into those really tiny, like, micro sized blood vessels, or capillaries, the really tiny ones, they're like single cell layer of the vessels themselves. So our white blood cells can squeeze in between the junctions of these guys. And that's called diapedesis, which is a term that you do need to know for the exam. It absolutely will be on the exam.
So that's just when a white blood cell or like a neutrophil is squeezing through the tissue.
Yes. Exactly. So most of this is going to be determined by chemotaxis. We're called there based on these chemicals that are being produced in that area. Of course, there is some benefit to edema. We're diluting toxic things in the area. We're bringing the cells and stuff the neutrophils arrived with that fluid to destroy the pathogen. So we needed that to happen. And they also, in the fluid, will have like fibrin and clotting factors and things like that that can help form clots to trap the microbes and to help begin the healing process. So it's not bad. All right, finally, at the end of the whole reaction is whenever we start seeing more of the monocytes, the macrophages, the lymphocytes coming in to clear up any of the damage and helping take the damaged debris and activating the lymphocytes even more. B cells will make their antibodies, and then T cells will kill the intruders or infected cells directly, and it will repair. Fevers are part of our inflammatory response. That can't be too surprising now that we've learned about the calor, the heat aspect of all of this. So fevers kind of an adjunct to this. We have different levels of fevers, of course. Fevers are stimulated by something called pyrogens. Yes, like a pyromaniac, like fire, heat, right? So pyrogens, heat, fever. You can be stimulated by stuff that's outside of the cell, so the actual like bacteria that are infecting you, the viruses, whatever that is, or something that's within the body. So endogenous, that would be our immune cells sending signals that lead to the actual fever production. So your body can be sending the signals, or the presence of these bad guys can be. So it's exogenous or endogenous. What are the benefits of fever? Why do we have it? It inhibits multiplication of temperature-sensitive microorganisms. It's more common than you might think. It impedes nutrition by, hoarding away iron so the bacteria can't have it. It'll slow down enzymatic reactions as a result of that. We have an increase in metabolism of our own body. So we can start speeding up hematopoiesis, phagocytosis, and our adaptive immunity. and having our lymphocytes come back to that area to come fight even faster. So it does stuff. This is good stuff. So do we treat our fevers? Most of the time, the theory now is that you should let a fever run its course unless it becomes high or you are concerned about it in some way. Of course, if it's your child, please follow, your doctor's orders. But for the most part, it's there for a reason. It does good. All right, next we have interferon. Interferon is one of these cytokines that can be produced by cells. Look at this picture. This is like one of my favorite things to talk about because I feel like I get to, I don't know. Anyways, it's about to get real in here, folks. Interferon, it's for viral infections, but it's not virus specific. So it's still part of the innate response. And what it is a molecule produced by an infected cell to warn the cell nearby or cells nearby. Okay, it doesn't even have to be the one immediately next to it, but it can send out the signal and cells nearby can respond. So Jim on the left is our first cell. Jim is getting infected with viruses, or one way we could look at it is he's getting attacked by burglars. Okay, and he says, "Oh no, I'm being invaded." He goes and hides. There's nothing he can do. He knows that he's done. So he goes in his closet and he's like, "I gotta call Kenny and warn him." So he calls up Kenny. His phone call, that's our interferon. Okay. Hey, we got a bad guy situation here. Kenny's like, "Yep, thanks for the warning, Jim. I have my shotgun ready." And he's ready at the door with his shotgun for these guys to show up. And his shotgun in this case is his antiviral proteins and things like that to keep the virus from being able to replicate. And it could potentially save him from being infected, or at least delay it. So that's how interferon works. It can also be useful. We can actually infuse people with interferon and other medications to help help with that whole response, I guess is what I'm trying to say. But finally, we have the complement system. Complement cascade is essentially a group of proteins in your blood. It's just like 50 proteins, and they're just chilling and they're not doing anything on their own. And they're always there. And that's good because they're always available to be triggered. We don't have to wait for them to be produced or anything like that. So what happens is they see a trigger, and one protein will see that trigger and reacts to it, and then it causes the other proteins to react, and then they cause other proteins to react, and that's why it's a cascade reaction. Okay, so it causes this literal cascade of all these proteins reacting to what's originally been seen. So it's a sequential physiological response where one molecule is going to activate the next, and so on and so forth. There's 3 ways we can activate the complement pathway, and you need to know all 3, and you need to know the differences. The first pathway is the classical pathway. It's activated by the presence of antibody. Antibody gets bound to the outside of a bacteria, and complement recognizes that and starts its cascade. Then next is the lectin pathway. Lectin is a molecule that recognizes certain sugars on bacteria that we don't have. So lectin binds to mannose or something, and then the complement protein interacts with that and starts its little cascade. Third way is interacting with repeating molecules. It's a lot like the PAMPs, okay? And the most commonly reacted to one is going to be LPS or endotoxin. So it could see that and then cause the cascade. So what is the cascade doing for us? Well, our steps involve initiation, which is just recognizing antibody, the lectin binding, or the LPS. One of those 3. And then we'll go through amplification and the cascade reaction. So it just gets stronger and stronger. You get one protein involved and the reaction is stronger and stronger further down the cascade. So that's the amplification. But the products that we make during that cascade reaction can help with inflammation, opsonization. So, and let's just start with inflammation. We already talked about what that is. So we're talking about helping trigger and strengthen that response, the inflammatory response. Sometimes you might not see this from stepping on a nail. So you'd want to have the inflammation going on in a different way. So this allows you to do that. We have opsonization. It's pointing to phagocytosis. Opsonization is a term that's going to officially show up in the next chapter, but you're still going to need to know it. But it's essentially just giving the phagocytes something easier to hold on to when eating the bad guys up. That's really all that's happening. So it's helping phagocytosis. Opsonization, aids phagocytosis by making it easier for it to happen. Okay. And then the last one, probably the biggest thing that the complement pathway does for us is the membrane attack complex. So this happens with polymerization. We have all these cascade proteins that'll come together, polymerize. We know what that is, polymers, many things coming together to create these little holes inside of the actual microbes outside membrane. And these holes will allow the microbe to leak out its contents and die eventually from that. So that's the membrane attack complex. That's the number one most important thing that complement will be doing for us as far as an innate response. This is just always in your blood, and it can be activated at any point, basically, by the presence of one of those three things up there. So you don't need to know the C3 and all that BS, okay? Just know the concept of what's happening. All right, so we had our initiation by those three things, classical, lectin, and alternative. We had our amplification and cascade, where we could introduce opsonization, helping out the phagocytosis and the inflammation. And then we had the polymerization with the membrane attack. So yeah, poking the holes in the membrane. So complement is going to help with all of these things. And it is one of the more important aspects of the innate response outside of like neutrophils actually eating things. So this is a pretty big one. And I'm sure that you guys can probably see in this, and maybe as we get into the next chapter, especially so, these responses are always all happening at the same time. So it's not like you only have innate or the acquired. They're all going at the same time. And one other thing you can look at it as is this. You stepped on your nail. We had those mast cells there. Remember in that image? We stepped on that nail and the mast cells were like, oh my God, no, bad guy. That stuff, but it can't do anything. It can't eat up the bad guys. It's just releasing its granules, right? When it's doing that, sending out those signals, think of it as a scout in the military. Okay, so the scout is out there just always watching the perimeter, and it sees this, but he can't do anything about it other than go ask for help. So the scout sees it, calls out for help. The neutrophils are brought in. This is like the Marines, okay? It's like the frontline guys that are all there like shooting with their guns and whatever. And they're like, we're not gonna be able to do this all by ourselves. So they call in the bombers. And the bombers are the lymphocytes, but they take time. You can't just take off in your bomber. You have to know where you're going. You make sure you have the bombs. You got to have everything put together and whatever. So in the meantime, the neutrophils are fighting the good fight while we're waiting on the bombers. And the person that goes and tells the bombers all of the details and gives them everything they need in order to know how to fight this fight, that's going to be the macrophages. So, yes. Kind of makes sense there in that regard, because we're going to learn about the bombers in the next one. That'll be I feel like the bombers are the like B cells, and the antibodies are the bombs themselves. But yeah, the T cells are a whole other thing, man. They're like the tanks. They're going for the kill themselves. So yeah, yeah, that's it. So we'll go ahead and go to the lab. We'll get back with the Kahoot stuff on Thursday. And for a lot of people were emailing you today or yesterday or something, I don't know, about how we didn't have a pre-lab today. That is correct. We do not have a pre-lab today. Today's lab is going to be pretty quick and easy. But that's on purpose. It's just so that we can get like kind of reoriented after the lab exam and